Assalamu alaikum. Today, inshallah, we will talk about acute AC injuries. We will start as usual with relevant anatomy. It is a synovial diarthrodial bland joint between the distal clavicle and the anteromedial part of the acromion. AC joint with its capsule, CC ligament with its two parts. The lateral part is trapezoid and the medial part of the conoid, and the CA ligament coracoacromial ligament. The orientation of this joint ranging from vertical to sloping medially about 50 degree. There is a lot of motion here. The clavicle rotate about 50 degree. 5 of them occurred AC and the remaining occur as the clavicular joint and synchronous motion with the scapula. But due to even this little amount of rotation and even translation, when you do a rigid fixation, you affect the shoulder function and there is an incidence of implant failure. So you have to remove once the ligament healed. Stability of the joint is either static or dynamic. We will start with dynamic. Deltotrapezial fascia. Anteriorly, this is the fibers of the deltoid along the distal part of the clavicle and the acromion. And posteriorly, superiorly is the trapezia. Both are covered by fascia. Deltotrapezial fascia. When you open it, please take your time to make a good flap for proper closure. If you don't close it properly, you will lose a lot of fixation. Regarding the static fixation, AC is 4 part. Acromioclavicular ligament is 4 part: superior, inferior, anterior, posterior. The superior is the strongest, followed by the posterior, because it is oriented transversely here. So transverse stability, AB stability, AC is responsible for it. This is the trapezoid part. This is the conoid part, oriented vertically, so it is responsible for vertical stability. Trapezoid component starting anterolateral here in the coracoid to the inferior surface, trapezoid line on the under surface of the clavicle. And regarding the coronoid, from posteromedial surface of the coracoid to the conoid tubercle on the under surface of the clavicle. Trapezoid insert about 3 cm away from the AC joint, and conoid about 4.5 cm away from the AC joint. So if you plan to do anatomical reconstruction passing the graft from the under surface of the angle of the coracoid, you will do a drill hole. After measuring by tab, you will do a drill hole 3 cm for the conoid limb of the graft, trapezoid limb of the graft, then 4.5 from the AC joint for the conoid limb of the graft. Again, this is the anterolateral part and this is the posteromedial conoid ligament, the same arrangement of the AC bundle, two bundle of the ACL. Again, this is the anterolateral part of the trapezoid and this is the posteromedial part. Some measures, the width of the AC joint is about 3 mm. And the vertical, this is transversally, and the vertical length of the CC space is 1.1 to 1.3. If this space is doubled or this space or distance is increased by 50%, this is a complete AC joint. Regarding the mechanism, I want you to know this is a scapular injury. The clavicle isn't elevated except in type 5. This is a scapular injury. The shoulder is sagged down. Direct trauma to the shoulder, direct trauma to the acromion, make it in adducted position, or indirect injury through falling on outstretched hand, making the humeral head impinge on the acromion. Regarding the natural history, with non-operative management, type 1, type 2, and most of type 3 doing well. With non-operative management, type 4 to 6 is doing very bad from chronic pain and instability. Regarding classification, Rockwood classification, I inform you, we have a static stabilizer, AC and CC, and we have dynamic stabilizer, deltotrapezial fascia. According to injury of this component, you will have clavicular displacement and CC distance change. Type 1 is only sprain in the AC ligament joint, but all other components, static and dynamic, is normal. So this patient is completely radiologically free. You have only some tenderness or some swelling on the AC joint. Type 2, there is a complete tear of the AC and sprain in the CC, leading to displacement of the clavicle. This is the inferior border of the clavicle, and this is the superior border of the acromion. If this border elevated but doesn't reach to the superior border of the acromion, this is less than 100% translation. This is type 2. If it is displaced at the same level, inferior border at the inferior border of the distal clavicle at the superior border of the lateral acromion, this is type 3. If more than this, this is type 5. More than this is type 5. Regarding type 4, this is the posterior displacement. Posterior displacement in the AB or Zanca view, you could not see any change in the AC. But if you do lateral axillary, this is coracoid. Everything and at this level is anterior, and posterior to it is posterior. This is the anterior part of the acromion border, and this is the distal clavicle displaced posterior to the coracoid. This is posterior translation, and this is type 4. Notice that in the lateral X-ray, you can see the coracoid if it is fracture or no. And there is also another better view, which is striker notch. This is type 5, and very, very rarely type 6 is a direct trauma to the clavicle itself, decreased below the coracoid and the conjoint tendon, not a scapular injury. This is a radiological example of type 2. Still, the inferior border is below the superior border of the acromion, less than 100%. So type 2, this is the exactly inferior border is the superior border, so it is 100%, so it's type 3. This is type 4, lateral axillary view. This is the coracoid process. This is the configuration of the coracoid process. This is the anterior border of the acromion, and this is the anterior border of the distal clavicle. Still, it is displaced posterior to it, so it is type 4. Type 5 is highly displaced. You have to know pseudo dislocation variant or physeal injury variant. In skeletally immature, the clavicle is separated from the periosteal sleeve. This type, which appear as if type 5 AC dislocation, isn't type 5 AC dislocation. It is a variant pseudo dislocation, and it is managed conservatively. This is the X-ray appear in the skeletally immature as if AC dislocation. Just with arm sling, it is remodeled completely. Regarding clinical assessment, as usual in all trauma, we start with proper history examination, focusing on the mechanism of injury, then followed by ELTS protocol, neurovascular examination, and compartment, and if it is open, this is the general scheme for all trauma cases. AC is a part of shoulder examination, so a lot of shoulder examination you can put in AC and do in your clinic in AC injury. There is shoulder asymmetry, some swelling, some sag of the shoulder, and tenderness here. You can inspect the skin for operation. You can delay some days of surgery until this operation re-epithelialized. There is a lot of associated injury also. And this is the debate between open and closed management. Some lag. Sorry for this lag. Associated injury mainly is supraspinatus partial tear and slab lesion. Please review shoulder examination for Joub test when you're doing forward deflection about 90 degree and the abduction 30 degrees. This is Joub test in supinations and pronation, and going inward about 10 degree of abduction. This is O'Brien test and differentiate between the slab and AC according to the pain site. If it is deep, it is slab, and if it is superficial over the AC, it is AC injury. Please review the management. Again, the leg. And you complete by cross arm abduction test you can do. Regarding the image, you have three routine image: AB, Zanka, and lateral X-ray. Regarding the Zanka, the difference between Zanka and the AB view is making the tube cephalically tilt about 10 degree to make the beam away from the scapula and scapular spine mainly, so decreasing the penetration of the X-ray. This is the lateral X-ray, this is AB, and this is the lateral. As you see here, normally this is the coracoid process, and this is the distal clavicle over the anteromedial part of the acromion. Here, this is the coracoid, and it is displaced posteriorly relative to the anterior border of the coracoid. As you see here, you can see if there is a coracoid fracture in the lateral X-ray, but more better through striker notch view. The coracoid is all in the profile in the striker notch view. The technique is to put the hand over the head. You have to know the technique. For the sake of completion, CT to detect any arthritis, MRI to detect signal changes, tear and or sprain. Indication for non-operative, type 1, type 2, and most of type 3, except in high demand patient, the overhead throwing athlete or manual worker, young with dominant hand. This is all make the decision towards, after discussion with the patient, towards the operative side. This is the non-operative type 1, type 2, and most of type 3, except in high demand patient, in the form of only ice and arm sling, and start rehabilitation as early as possible. Regarding the indication of surgical management, from 4 to 6, you have to prevent chronic pain and chronic instability. Techniques of operative fixation, either to fix the AC or to fix the CC. To fix the AC through hook plate, pins, and K-wire is obsolete now due to migration. CC recently is by either tightrope or dog bone button fixation. This can be done either open or arthroscopically. Arthroscopic ARG is due to associated intra-articular lesion, which is supraspinatus tear and slab lesion. We will take in details later, inshallah. Or less commonly, ligamentous reconstruction, obsolete dynamic muscle transfer. Hook plate is very rigid. This is the most advantage of this. The problem of CC fixation is a lot of implant failure, a lot of stresses here. So hook plate is very rigid fixation, but the problem is that hook is under the acromion and it could penetrate or doing osteolysis here. So, and arthritis in the AC joint. So within 6 months you have to remove it until the CC ligament heal with fibrous tissue. So one of the most common withdrawal of this plate is it needs a second surgery. This type of fixation, dog bone button fixation, is done either arthroscopically or open. You need to do a drill hole to pass this tab, and this larger area button make less stress on the bone, so decrease the incidence of fracture and penetration, and at the same time it doesn't pass through the bone itself, so it doesn't need a huge drill hole. In comparison to, this is the X-ray appearance. In comparison to tightrope is the same idea. This is both are suspensory ligament fixation, suspensory type of fixation of CC. You this longitudinally oriented bottom, you have to pass it through the coracoid, so it is a metal, not only a tab or a string. It is a metal, so the drill hole is enlarged. So the potential for fracture either in the coracoid or the clavicle is increased in comparison to the dog bone button. And the controversial between arthroscopic or open is due to the associated intra-articular lesion make arthroscopic fixation is more favorable. This is the radiological appearance. This longitudinally oriented is, he passes it longitudinally here, then withdraw the string and become horizontal, so it is locked below. This is the radiological appearance. Both worst screw is historical. One screw, either 4.5 or 6.5 from the clavicle to the coracoid, is obsolete nowadays. Clavicle fracture, screw fracture, or coracoid fracture will occur. Also historical for acute, the CA ligament, coracoacromial ligament, he detached it from acromial side, and after resection of the lateral 1 centimeter of the clavicle, reattach it to compensate for the CC ligament. Now it is obsolete. Please answer this question and inform me about the answer. Special thanks and appreciation for Prof. Osama Saleh. He helps me a lot in this difficult lecture. And thank you all.